I'm using the backup. Can you hear me?
Yes, I can.
Yeah, I've got to begin to trust the backup.
Yes, John.
Because, there will be problems sometimes. I haven't really had to use it on an emergency basis yet, knock on wood, but I can see, because my desktop will crash.
Mm-hmm.
I think we're going to have a good number of people today.
Yeah, we will. I'm
I
sure.
snored a lot. I couldn't sleep.
Why?
I woke up at 2:00. I couldn't sleep.
Because of Ecuadorian Grand Rounds or what? Or Venezuela?
Oh, because things are going so well. Things are going so well.
Good.
And you are a part of that.
Thank you, John.
Well, to have someone help like you are, it's tremendous, really.
Mm-hmm.
I couldn't make any traction in that Russian community. I could not do it. And I don't want to let it go. I told Aaliyah this morning, I said, Aaliyah, can you let me know ahead of time? Because they let me know like the day before. Well, how can you promote? So how you doing? So I told her, well, tell your boss you won't come to work until you tell her when the next webcast is. And she's going to try that.
Okay.
Hello, Kwan. How you doing?
Hello, sir. I'm very good, thank you.
How you been?
I'm doing very well.
Good. I'm John Bennett of Neurosurgical TV. And have we met you before?
Not yet.
Oh, good. Welcome.
Where are you from? Hello.
Hello, I'm from Vietnam.
Vietnam. We've had webcasts with Vietnam before.
Do we?
Yeah. Well, no, a long time ago. We haven't had about a year ago or so from the capital.
Hanoi.
Okay.
Yeah, from the capital. Yeah.
Hanoi. Okay.
Mm-hmm.
So, yeah, you're welcome to come to any webcast. And if you guys want to televise, they're free.
Thank
So
you.
if you let us know you have a group of neurosurgeons, just let me know, Mr. Bennett, we want to televise something. Okay?
Are you a resident?
Okay, thank you. Thank you very much.
Are you a resident or already neurosurgeon?
At the moment, I'm just finished the resident.
Okay, great. Congratulations.
Okay. Nerissa, I was talking to you for about 5 minutes.
Me?
I thought you were ignoring me. But
No,
I was muted. I was wondering, boy, she's not reacting when I was saying. Oh, I'm muted. I'm just talking to the air.
yeah, I saw that you joined your second this John Bennett background stuff, and I was like, okay, fine, but then
Yeah, it gets confusing if I have two open. I mean, because I can't have an audio on. I gotta pay attention to it. So
yes, otherwise it will be equal. Just
yeah,
1
yeah,
second.
yeah, sure. Yeah, I'll be back in a few minutes.
Yeah, I'm here. I just have to change my seat.
Nagisa, I'm gonna make you co-host, okay? Because there were some people I miss admitting.
Okay, thank
This
you.
My co-host. And that way you can admit people.
Okay, I can invite, mute all, more. They go straight into the room. Oh, okay, okay. See, this is different. I'm learning. A meeting, you don't have to admit them to the panel. They're in the panel. You know what I mean? Whereas the webinar, you have to admit them. Okay,
So
okay.
that's a pain, especially if you don't know the speakers, you don't know. Sometimes they use variations of the name, or they come in on their buddy's computer device. We're gonna have a good crowd today.
So, Boris Jurovich entered the waiting room. Okay, admit?
Yeah, there you go. You admitted them, right? Yeah, admit everybody, because that's why they came. You wouldn't be mean to them, right? And have them wait in the waiting room?
Who else is
You
there?
wait.
Mon Bombardier, Boris Jurovich, and
Yeah, we just arranged this yesterday. I didn't think he was gonna do it. But I figured, what the heck, why not? But he'll be surprised. We got some people. I don't think he thought he'd have anybody. But since I got up early, I couldn't sleep. I was just so excited. Because I have to promote a lot of things. You know, it's not just yours, or it's like seven different ones. Sometimes I forget to pay attention to one, etc. It's a lot of manual stuff.
which I don't expect you to do. I need to get someone that can do it.
Yes, you have to get someone who has more free time.
Well, I'll just try to have you do the minimum possible, and hopefully Kurt will help you. I talked to him yesterday,
Mhm.
and he's one of these idiots. What time? It's Moscow, but what time is it in Hawaii? Well, Kurt, this is how people travel on the plane. What do you think they do to figure out what time they're going to arrive? What do you think they do? I don't say that. I say it to my brother, but if it's someone else, I don't say that.
You can say it to Kurt. He will not be upset.
I know you'll just laugh. But it'd be good for him to start to use Russian again and to do something intellectual, because he's been doing building waterfalls in Maui. And he's a college graduate, a smart guy. And building waterfalls, that's okay. But you gotta use your brain now. It's time to use your brain before you croak. Okay, I'll be back, okay?
Yeah.
Gotta do some stuff. Yeah, Nargisa, one thing that's
Yeah.
going to happen is conferences, I think, in my opinion, they're going to become less in-person conference and more virtual. I think it's inevitable. And I think what I may start to do is try to get people to televise their conference on the net and charge for it.
Mhm.
You know what I mean? They do that with other things like $50, $25 to see their event, whereas it would cost $300 or $400 to go there, et cetera, et cetera. That's a valid revenue stream. So I made a bid this morning for an Indian webcast. Oh no, Pakistani, big one that I'm going to televise it anyways. It's just going to be on YouTube.
Pakistani, you mean Professor Salman Sharif?
Salman, no, I forget the Dr. Nair, I believe. Usually Salman Sharif is the leader.
Dr. Nair is the woman, right?
No, this is a man.
Mhm.
Yeah, well, anyways, that conference, I haven't mentioned to him, but because he said, yeah, you can pick up the feed on our YouTube channel. You know what that means, right? When I just pick up the feed, in other words, they're televising it on YouTube and putting it on a YouTube channel. But I can take that. The public can take it, the code from the internet, YouTube, unless they turn that off and say no one can copy it. But most people leave it on because they want you to live stream it from your channel or your website, like I would do. They want it because they want wider dissemination. It just makes sense. So if that stream gets open, wow, that would be great. That would be great. Then every conference would want to, especially if you built a record, every conference would want to hear from you. I said, hey, we want to make money from our live televising.
Mhm.
You know, so it's kind of tough for them because they don't want to advertise live because they're afraid people will not buy tickets and go to it, which, you know, kind of a question that needs to be answered.
Mhm.
Does anybody else want to bother Nargiza? I think I'm bending her ear. Anybody else there want to give her ears a rest?
Oh, please. John, did you put the date 26th of November? I asked you yesterday.
We'll talk later, okay? We'll
Okay.
go over the schedule.
Yes. Mhm.
Yeah, I need to erase today. I had a Russian, I don't know why I had it scheduled. See, Brazil just asked to televise. I mean, it's really going really good. On Monday.
On Monday, they want to televise, okay?
Yeah, and there were a couple of people yesterday, because I used to have to search to get them. I used to have to, but now they're coming to me,
Mhm.
which is great. So we're gonna ride it. Okay, let me check. I think there's someone in the waiting room. Oh.
Yeah, I'll admit.
Well, Hashan doesn't look like he's here. Do you want to introduce James? Giva? Hi, James. Good morning.
Good morning.
Can I Good
There you
morning.
go. We got 6 minutes. We got some people. I'm surprised. I thought with a late start.
Oh, that's great. Good
Yeah.
turnout.
Yeah. Well, part of it was I got up early at 2 o'clock today. I couldn't sleep.
Must have been my late text.
Yeah, could have been. You got any OR today?
No. I'm gonna rest today. I had a long day yesterday.
Yeah. You know Nargiza, right?
Yes, we met last time.
Okay.
Hello, good morning.
Good morning.
So you practice in Russia or no, I'm sorry, Uzbekistan?
Yeah, right now I'm doing my fellowship in Istanbul, but I will be doing practice later on. So
Oh,
I'm
okay.
still learning. I have done my residency in Russia.
Uh-huh.
Yes.
Where in Russia, in the Federal,
Siberia. Siberia.
yeah, in
I
Tyumen?
have sent you, no, Novosibirsk. I have sent you a Gmail
Okay.
last week. I put the name of the university with website where
Okay.
I have done. So yes.
My resident
He's,
also trained in
you
Russia.
were telling he's from Siberia,
Yeah.
probably. But Siberia include I don't know how many, at least three big cities and smaller. So they have two neurosurgical centers. One is in Tyumen, another is in Novosibirsk. So Moscow, St. Petersburg, and smaller centers they also have.
Who are you studying with in Istanbul?
I'm doing pediatric neurosurgery fellowship with Professor Mehmet Uzek.
Okay, great.
Yes, he's from Acıbadem Institute. So,
Oh, okay, yes. I did a webinar for them last year
okay.
with
They have adult and pediatric department. So adult is Professor Necmettin Pamir, and the pediatric is Professor Mehmet Uzek.
okay. Yes, I know Dr. Pamir.
Yes, he expert in meningiomas, also is Calvase.
Yeah.
So Nargiza, can you introduce Dr. Leo?
Okay.
Yeah, just look real quick
Just give me one
at
second.
the bio because Harshad didn't, he was going to come, but he hasn't showed up.
Mhm. Give me a few minutes.
So Perhaps if you look at the banner, Giza,
Yes, yes, I am.
yeah, most of it's there. James, next weekend schedule is huge.
Oh yeah, that's like
100 and
100 speakers.
more than that. I think 120, 130.
Well,
I don't know how he did it.
you can imagine though, if 5 speakers don't stay on time, you could be delayed a few hours.
Yeah, it's touch and go. It's nerve-wracking sometimes. And sometimes people don't show or audio problems or whatever, but it's worth it. We're not real serious, and it's the best, I think it's the best group ever on the internet, on the web. Me, in my opinion. It hasn't been done before. I mean, and of course, it hasn't been done live because so many different neurosurgeons. But I don't think it's ever been done on the internet. And let's do the same.
Doesn't Zoom have a time limit of how long you can?
Yeah, they
Okay.
do, and it does scare me because we're gonna have to take note of that. They Zoom cut, I was in the middle of a webcast after about 8 hours. Usually it lets you go to 10 to 12. But the first time it's ever happened, Zoom just cut off the website cast, which wasn't very nice. I hope it's not a precedent. I hope they're not getting strict because they say 8 hours, they say, and they tell you. But we may have to cut it up and say, okay, you have to change. Okay, you ready to start?
Yes, we can.
Ready, Nagisa? Ready, James?
Yep.
Okay.
Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2. Good morning. This is Dr. John Bennett from Neurosurgical TV, home of Miami Beach, home of Neurosurgical TV. We have another in the series of the Art of Brain Surgery Masterclass, and I'm going to have Nargiza from Uzbekistan give an introduction, a neurosurgical introduction to James. Welcome, Nargiza.
Good morning, good afternoon, and good evening, everyone. It's an honor to be here today. And again, we are back to the interesting lectures of James Liu, medical doctor, professor, and director of cerebrovascular skull-based pituitary surgery, co-director of endoscopic skull-based surgery, program department of neurosurgery, Rutgers University, New Jersey, USA. This week, today, we are going to talk about acoustic neurinomas. Please, Dr. James, we would like you to start the lecture. Thank you.
Thank you, Nargiza. Thank you for the kind introduction. And thank you, John, for hosting. Let me share my screen. Okay, can you see my screen?
Yes, we can.
Okay, terrific.
Mhm.
Well, this morning I'm going to share a topic that's near and dear to my heart, and that's acoustic neuromas. And I believe acoustic neuromas are very challenging in many ways. Challenging in the sense of decision and management, counseling with patients, and also the technical aspect. And I think it's one of the most challenging surgeries to do well, especially when it comes to removing the tumor and sparing cranial nerves. So let me share with you some of my thoughts on this topic. As you know, acoustic neuroma, the correct term is vestibular schwannoma. They are schwannomas histologically, and they arise from the vestibular nerve. But sometimes old terms are hard to remove because acoustic neuroma is very easy and very ingrained in our brain. So For the purpose of this talk, I will use the term acoustic neuroma, a classic old term, but they account for about 10% of all primary brain tumors. They have a wide variety of clinical manifestations, growth patterns, as well as outcomes. And patients typically will present with unilateral high-frequency sensory neural hearing loss, sometimes associated with vertigo and dizziness, and also tinnitus, sometimes headache. And of course, you can have balance and gait problems, either from vestibular dysfunction or brainstem compression. So these tumors come in a lot of different flavors. You have these small ones, which I call the good, and then the bad. And of course, there's the ugly, these larger giant ones with severe brainstem compression. There are some classifications that we like to use. This is the classic Coos classification, very easy to remember, 1, 2, and 3. Tumor here starts in the intracanalicular space. Once it crosses the cistern but does not touch the brainstem is Coos grade 2. And once it touches the brainstem, it's a grade 3. And if it starts to compress the brainstem, it's a grade 4. I usually like to tell patients that it's like crossing the tunnel across the river to reach the land. So here in New Jersey, we like to say, this is the Lincoln Tunnel. Your tumor crosses the Lincoln Tunnel and then crosses the Hudson River. And then you make it over to New Jersey. And once it starts compressing New Jersey, these tumors can be a big problem. So the other classification that you should be aware of is the Hanover classification by Professor Sami. They're a little bit more specific when it comes to the larger tumors, whether it's compressing the brainstem or displacing the fourth ventricle. And this is important to know when we're reading our literature. It's also important to know the different hearing classifications. This is the American Academy hearing scale, looking at the pure tone average and then the speech discrimination, A through D, and then there's the Gardner-Robertson hearing classification as well. So it's important to know the 50-50 rule. Most people use the 50-50 rule as the less than 50% speech discrimination and greater than 50 decibel pure tone average as non-serviceable hearing. And in the American Academy, they typically use a 30-70 rule, where if the hearing is less than 70 speech discrimination and greater than 30 decibels pure tone average, hearing starts to become less serviceable. Again, the facial nerve classification is important. The House-Brackman scale, which you are all very familiar with. We like to say that House-Brackman grade 1 and 2 is excellent, pretty good facial nerve outcome. 1 is perfect. 2 is very subtle asymmetry, barely noticeable. And of course, 3, the weakness is worse. And of course, 4, you don't have good eye closure. And 5 and 6 are the worst outcomes, to minimal movement to no movement of the face. So we want to aim our outcomes into grade 1 and 2 as excellent outcomes. Treatment strategies, we like to say that there's different treatment strategies when we're counseling patients. We have observation, which is wait and scan, surgical resection with removing the tumor, and we have 3 approaches when we talk about surgical resection: retrosigmoid and middle fossa, highlighted in yellow, can potentially preserve hearing because we don't drill through structures that can impair hearing. And of course, translabyrinthine approach automatically will eliminate any existing hearing, because by nature of the approach, you drill through the labyrinth. And of course, radiation therapy, typically in the form of stereotactic radiosurgery, and then fractionated radiotherapy as well. So when we see these patients, these consultations, at least in my practice, typically take almost 45 minutes to an hour. Patients usually are very sophisticated and they come prepared with lots of questions. And these are some typical questions. Why choose radiation over surgery? Why choose surgery over radiation? And at what point do you recommend surgery? And if you do choose surgery, what approach has the least amount of risk? And at what point do you recommend treatment over just simply watching and waiting? And so this typically results in, a lot of different questions, a lot of different paradigms, and, patients can, often, get lost in the shuffle and be very confused. And so we have to really take into consideration everything involved. It's a holistic, individual, tailored approach, as I call it. You sit down, you get to know the patient, you take everything in whole: the age of the patient, the size of the tumor, where its extent, is it compressing the brainstem? What is the preoperative hearing status? Make sure you study the audiogram, make sure the patients have the audiogram reports when they bring it to your office. Is there any balance or dizziness issues? Is there brainstem compression? And of course, you need to discuss all of the risk factors for every treatment, whether it's radiation, watching and waiting, and of course, the surgical complications, as we all know well, that can happen, cranial nerve palsies, CSF leak, brain swelling, and so forth. And it's also important to take into consideration your own personal track record, because when you speak to a patient, you have to quote your own results. It's not fair for you to quote someone else's results reported in the literature, because not every surgeon has the same results. So that's very important. It's important to know whether your surgeon is working by himself, or if he works with a skull-based team with an ENT surgeon, and whether the intention is going to be a total removal or an intentional subtotal removal followed by radiation. So long-term outcomes are important, and it is our job to help navigate the treatment options with the patient, because, like I said, these discussions can be very confusing, very lengthy, and it's important to make it simplified and break it down for the patient so they don't feel like they're being torn in all directions. Like I said, treatment strategy should be tailored and individualized to the patient, and it's very important to know that not one size fits all. Okay, we have to be tailors. Let's talk about the smaller tumors first. Okay, these are the Coos grade 1 and 2 tumors. This is a 38-year-old female, mild to moderate hearing loss on the right, has vertigo, and basically neurologically intact. And you can see the tumor here is quite small, intracanalicular. What are some important features about this tumor? Well, you could see that the tumor is right here in the canal, and there's a CSF signal here. We call this the fundal cap. And you can see the posterior semicircular canal is going to be roughly in this direction. And so she's a young patient, some mild hearing loss. We can simply observe. It's not a tumor that's going to be a threat to the brainstem. You can certainly radiate it. That's certainly an option. And what does radiation do? Radiation will offer pretty good 93 to 95% tumor control, meaning that it stuns the growth and prevents it from growing further. But it also means that there's probably about a 5% treatment failure where the tumor can progress and continue to grow. And we hope that the tumor stabilizes the growth and does not affect the hearing. The tumor has a good distance from the cochlea here. Here's the cochlea. So there's a good distance. So I think the risk of accelerating the hearing loss might be less than if we're a tumor located more closer to the cochlea. And of course, there's also surgery where our goal is to remove the tumor, save the facial nerve, but also try to save the hearing since the patient has normal hearing still. And you can do this through a middle fossa or retrosigmoid approach. So given all the options, this is the patient's discussion. She actually did not want to have radiation, but she wanted to have the tumor out, and with the hopes of preserving hearing. So in this case, we chose the retrosigmoid approach. It's very favorable. You could see we can drill the posterior meatus and get distal to the fundal end of the tumor. There's no temporal lobe retraction. And by coming in this direction, retrosigmoid, the facial and cochlear nerves are on the ventral side of the tumor, whereas in the middle fossa, the facial nerve tends to be on the anterior side, and sometimes it can be on the dorsal surface of the working area, which can potentially increase your risk of facial palsy. And so here's the angle of attack that we take. And this is the classic retrosigmoid approach, C-shaped incision behind the ear. And we drill out the internal auditory canal in a 270-degree fashion. We drill a trough above the IAC and a trough below the IAC. And we use this technique called the Fukushima V-cut technique. The tumor splays the vestibular nerves, and it forms this cleft where you can follow the tumor capsule and you can peel it off of the vestibular nerves, and we pick up the vestibular nerves and we save this vestibular nerve layer called the perineurium, and this perineurium protects the facial and cochlear nerves on the opposite side, and it's a nice buffer to protect it. And you can see the facial nerve here stimulating at 0.05 milliamps. This is a good prognostic factor that the facial nerve is firing, the signals are intact, and the cochlear nerve here is preserved, and the ABRs were preserved. So this patient had an excellent hearing outcome. Here we put a little fat graft where we drilled the IAC, and this is the fat signal on the MRI, and you could see she had an excellent postoperative course, no CSF leak, and this is a House-Brackman grade 1 result with preserved hearing. This is another case. This is a patient, 65-year-old, who presented with tinnitus in 2009, good hearing, and she chose observation. You could see the tumor is very small. It's right here, tiny little tumor in a 65-year-old, observation. Observation is obvious choice. But look, in 3 years, the tumor has grown with now complete hearing loss. So the hearing is now absent, and you can see the tumor is much more visible, obvious interval growth. Here you can see the image on the T2 scan that's filling the entire internal auditory canal all the way out to the fundus. And so in this case, we chose a retrosigmoid approach. You could see a complete removal, normal facial nerve function, no CSF leak. So let's talk about the growth of these tumors, right? This is a case that was observed, and it was probably detected incidentally. So it's very common to detect a tumor based on an MRI for another purpose. And when we're faced with these incidental tumors, we have to make a decision on them. And we usually like to talk about the natural history and what is the growth rate. So if you tell a patient, let's observe this, you need to let them know, well, what is the growth rate? And not all tumors grow at the same rate. Some grow faster than others. It's hard to predict which tumors will grow faster, which ones will grow slower, but we do know from statistics, the overall mean growth rate is about 1 to 2 millimeters per year. And sometimes the tumors that are growing tend to grow a little bit faster. And it's also important to remember that cystic tumors can grow a lot faster than solid tumors. And it's actually because the cysts are expanding with fluid. So the change in the size of the tumor can be rather fast. So if you're watching and waiting, what should you know? Eventually, everyone will lose hearing if you wait long enough, and it's usually about 10 years. All roads kind of lead to Rome. Hearing loss is not linear. It can vary as with tumor growth, and you need to be diligent with the interval MRI follow-up, okay, with MRI, but also getting periodic audiograms. And hearing preservation rates of 69% at 10 years for class 1 and 38% for class 2. So what does that mean? It just means that with the bigger tumors, there's a shorter time to complete hearing loss when you're watching and waiting. So it's not only it depends on where you're starting with the size of the tumor and where you're starting with your hearing status. Radiosurgery. What should you know about radiosurgery? Well, they come in different brands. There's Gamma Knife, frame-based, or sometimes frameless, and then there's CyberKnife and Linac-based systems. This is a nice paper from Hasegawa, which I frequently quote. Is they have excellent tumor control, 93%. What we need to dispel is the myth that the tumor shrinks. And oftentimes patients come in and they say, hey, can you shrink the tumor? And the tumors often will contract, over time, but they don't disappear or melt away. The tumor is still present. There is a 7% treatment failure. And for the larger tumors, CUS grade 3 and 4, the tumor control is not great. And yes.
How did it feel out there? Yeah, it felt amazing. I mean, I was here saying
the tumor control is not great, and you can still have persistent symptoms from the brainstem compression. So this is where surgery is important, because you need to achieve brainstem compression in some cases. 2 to 3% can form delayed cysts, and the quoted malignant transformation rate is about 0.3%. It's very rare. The percentage is very low, but there is some risk of developing malignant tumors after radiation. So the hearing preservation, 71% for class 1, and at 5 years, 64%. So like I said, those with worse hearing status to begin with tend to do worse because you have a bigger tumor and your hearing status is also at a lower point. This is an article from Mayo Clinic. Most of the tumors were small in this series, and the audiometric follow-up was about 9 years. And what they found was that the pre-treatment hearing status and tumor size were significantly associated with time to non-serviceable hearing. So the durable hearing preservation after 10 years is about less than 25%. And here you can see the Kaplan-Meier curve showing that 82% deteriorate to non-serviceable hearing at a mean of 4.2 years. Okay, so although radiosurgery gives you good overall tumor control, the long-term hearing preservation remains questionable. So, in fact, radiosurgery can potentially accelerate the hearing loss. And again, that has to do with the dose overspill to the cochlea. So, like I said, all roads lead to Rome. Most patients will eventually lose their hearing as a result of either radiosurgery or the natural history of the disease. And of course, surgery can also accelerate hearing loss as well. So what are the favorable factors for radiosurgery? Small tumor size, if there's a good distance to the cochlea with the fundal cap, And you got to have good, excellent pre-treatment hearing status, probably class 1. And, you want to minimize that dose to the cochlea to less than 3 gray. So let's talk about the medium-sized tumors. This is a 62-year-old female presented with right-sided hearing loss that was non-serviceable. She had severe gait ataxia, probably due to compression of this tumor, but look at the scan here as well. She's got some hydrocephalus, and that can also contribute to her gait ataxia. And you can see it's a decent sized tumor, probably 2.5 centimeters. Pretty impressive brainstem compression. So I often hear the people throw around the term of, hey, a tumor less than 3 centimeters, good candidate for radiosurgery. Well, this is a tumor that's less than 3 centimeters, but look how much brainstem compression there is in even a tumor less than 3 centimeters. And that's because everybody's anatomy is different. Not everyone has the same size CP angle cistern. Some people have very narrow cisterns where even smaller tumors cause great degree of compression, as in this case. Very important to study the temporal bone. So if you look at this temporal bone, this is very pneumatized, hyper-pneumatized temporal bone on this woman. What does that mean? What is the implication? Well, the implication is that you can get a high risk of postoperative CSF leak because you have many opportunities for any violation of an air cell to be a potential source for CSF fistula if it is not sealed off properly. So you can imagine if you did this retrosigmoid, look at this humongous space here on the anterior side. If this is not sealed off properly with bone wax or cement, you will have big CSF fistula. And plus, the patient has hydrocephalus. So the hydrocephalus will have increased CSF pressure and will drive that fluid into any potential airspace and give you a CSF fistula. So what should we do? How should we treat the hydrocephalus? Should we just take out the tumor and hope the hydrocephalus goes away, or do we treat the hydrocephalus first? This is not a straight and easy answer. I think there's different options that you can do. But because the patient had the hyperpneumatized temporal bone, my strategy here was that, like I said, these are the different options you can do for this patient. But what I ended up doing was I chose to shunt the patient first, treat the hydrocephalus, get the CSF pressures down, and then I took her back for a translabyrinthine approach. She had a very favorable temporal bone to do a translab, and it gives me this angle to the brainstem. It's a more lateral angle to the brainstem, and you don't use any cerebellar retraction. And this is the typical position. We use a C-shaped incision, supine head turn, and here you can see, here's the sigmoid sinus. This is the facial nerve. This is the fallopian canal. And the tumor will be in this pre-sigmoid space. This is the tumor that's expanded the IAC. We have great lateral control of the lateral pole of the tumor where we can start peeling and find the facial nerve distally. And then this is the medial side of the tumor, peeling it off the brainstem. And then this is the facial nerve at the end here. You can see it's nicely preserved. And here's the pre-op. Here's the post-op scan. And here's a post-operative course. She had very mild weakness initially post-op, but at 6 weeks, it returned back to completely normal. And she had improved gait function and no CSF leak. This is a 63-year-old male presented with progressive left-sided non-serviceable hearing loss. So here the hearing loss is complete. You can see again, large tumor here. Look at the big CP angle cistern he has. So he has larger tumor than the previous patient, but very little brainstem compression. Only this part that barely touches the brainstem. So you can see not every patient's anatomy is the same. Here we did translab. Again, this is a left-sided approach. Here's the sigmoid sinus. Here's the tumor filling the pre-sigmoid space. And look, there's no brain retraction. The tumor is right there in front of you. And then we go ahead and debulk the tumor. And here's the facial nerve. Facial nerve is nicely preserved. The brainstem is decompressed. This is the AICA vessel. And I want to show you some of the techniques that we've developed for repair of translab approaches. This is called the fascial sling technique, which we've published. So after you've taken out the tumor, we use fascia lata, and we suture the fascia lata in several places to hold it down. So it acts like a net or like a hammock, and it can hold the fat graft. And then we put the layers of fat over it to fill the mastoid cavity. And then we put a plate over this to put pressure on the fat graft. So this is the tumor. Here's the tumor removed. And then we use the fascia lata as a sling. We suture it in 3 or 4 different places. And then I also like to seal off the mastoid antrum by using a bone wax plate. You need to seal off the mastoid antrum that goes to the middle ear so you don't get CSF leaking into the middle ear. And then after I wax it, I put a layer of this bone cement. And then I can do the multi-layer closure with the fat. And then I put the plate over the fat to hold pressure on it. It's like an internal pressure dressing. And you can see this is the MRI showing the tumor before. This is the tumor after post removal. And you can see this is a T1 non-suppressed image where you can see the bright signal of the fat graft, which is asterisk. And if you do a fat suppressed MRI, you can see the fat signal goes away and you can see the bright signal of the fascia lata. This is the fascia lata sling. You can see the fascia lata sling, and then here's the fat filling the mastoid. And the advantage of using this technique in my mind is compared to the traditional technique, which is you put the fat from the bottom and you stack it all the way up. This technique prevents the fat from touching and potentially compressing the brainstem. So if you look at some of these scans where people use the traditional technique, it looks like there's a finger of fat like pointing at the brainstem. So I like this technique a lot better. Here's the post-op facial nerve result. Excellent result here for this gentleman. So lastly, let's talk about the ugly. I mean, these are the challenging, difficult tumors because there's a lot of brainstem compression. Here surgery is the answer, and you need to decompress the brainstem. Obviously, it's also very challenging because these larger tumors, facial nerve can be at risk when you're removing them. So here's a 68-year-old male, progressive imbalance, gait difficulty, leans towards the right side. Usually in these larger tumors, most people have lost their serviceable hearing at this time. So he had non-serviceable hearing, but he's got a pretty big tumor here. You can see how it's knuckled into the brainstem. Observation is not good here. Radiosurgery alone, not a great option in my opinion. So you need to surgically remove it and decompress the brainstem. Again, these are the options. You could do a retrosigmoid or translabyrinthine. I think here the answer is pretty straightforward. Look at the big cistern here. Retrosigmoid gives you a straight shot. I think one thing that helps me determine which approach I'm going to use is I look at the long axis of the tumor. And here the long axis of the tumor is this direction, and it follows the course of the petrous, the surface of the petrous bone. So it gives you a direct line of sight, and you can see with a favorable cistern like this, you're not really going to have any, brainstem retraction. And I think this is the question that, most people ask, what is your extent of resection? Are you going to get a gross total? Are you going to get a radical subtotal or near total? Or are you living a small bit behind? Or are you just going to debulk and do a subtotal? And we'll address this question in a moment. And then, of course, radiosurgery alone, I don't think is a great option here. And I'm going to talk about this in a moment, the combined strategies of subtotal and then radiosurgery. In any event, this is the patient. You start off by debulking the tumor in the CP angle. We could peel the tumor out of the fundus. This is the facial nerve in the internal auditory canal. We're peeling it off. And then here's the final view. In this case, this was a radical subtotal. You don't see much on the MRI scan, but I know this because I did the surgery and I purposely left a very tiny, thin remnant that was adherent to the facial nerve so that I would not impair facial nerve function. And this was him after surgery. His gait, ataxia improved, and his face was normal. This is another large tumor. This one is unique in that it is cystic. And so you need to know that cystic tumors are much more challenging because they tend to be more sticky, more adherent to facial nerve, but in some cases they can also be more vascular. And this was a physician who was working with me, and you could see she's got this large tumor compressing the brainstem. We went ahead and did this retrosigmoid. This is a Fukushima lateral position, which I often like to use. And we do a craniectomy. And here is the cystic tumor. Look how cystic membrane that you see here. You can see the hypervascularity on the cyst wall filled with proteinaceous fluid. And what you should know is that sometimes you can have vessels that are encased by these tumors. And so be careful. Don't quickly coagulate these tumors. You might end up coagulating an important vessel. In this case, it's the aica, piercing right through the middle of the tumor. And so we had to carefully dissect that vessel out and preserve it. And then you could see we preserved the aica. I left some tiny remnant of the tumor on the vessel so I wouldn't injure it. And you can see you have to skeletonize and follow it. So then once you free it up, you can move it out of the way and then work on the tumor and then remove the rest of the tumor. We find the facial nerve at the brainstem. We're stimulating it well. And then this was a radical near total removal. You could see I left a little bit of residue on the aica and maybe a little bit on the facial nerve. And then this is her in recovery. This is a very mild House-Brackman grade 2. And then within 6 weeks, it came back to a House-Brackman grade 1, and she was able to go back to work immediately. This is a young woman, high school cheerleader. She presented with this large tumor, complete hearing loss. You could see very severe compression of the brainstem. We did a radical subtotal. I left a tiny residue on the course of the facial nerve. But this is her. At 6 weeks, she was post-op Brackman grade 2. Beautiful smile, great eye closure. So how can we do this? Total or subtotal or near total? And I think there's emerging literature advocating for near total resections. And if we do perform a subtotal, how much can or how much should we leave behind? And so I wanted to address this topic of how to maximize the extent of resection using a technique that's been described called the subperineural dissection plane in order to preserve facial nerve function for large acoustic neuromas, COOS grade 3 and 4. And so as we can all agree that one of the major treatment objectives in acoustic neurosurgery is preservation of the facial nerve and getting a gross total removal if safely possible. And in recent years, there's been an increased interest in a concept called planned subtotal resection followed by gamma knife radiosurgery. And in the literature, this has been called the adaptive hybrid surgery technique, where you could see you have a tumor like this, you debulk the tumor, but only on the inside. You put a Sonopet or CUSA or whatever device you want to use, and you put it in the middle and you decompress, and then you use a stealth image guidance to figure out where you are, and then you back out and you say, okay, I've done enough decompression, gamma knife radiosurgery for second stage. This is called the adaptive hybrid technique. There's some criticisms though. There's been some concern that this technique has enabled less experienced surgeons who work at non-specialty centers to do all these surgeries. Because now you've said, well, you don't really need, high-level microsurgery skills, how to dissect the tumor off the facial nerve. You could just go ahead and put the tumor aspirator in the middle and you're done. So this can be a potential problem. Here's a case of mine. Patient was treated out in the community where another surgeon did a retrosigmoid and told the family we got most of it. The rest is inoperable and we could shrink it with radiation. So you could see this patient was given wrong information. The tumor actually looks like the same as the pre-op MRI. And unfortunately, this patient got a huge dose of radiation and 3 months later was quadriparetic, nonverbal, non-ambulatory, sitting in a hospital ward, being counseled by an internal medicine team about hospice end-of-life care. This is tragic. This is incredibly tragic. This is a benign tumor, a treatable benign tumor, and the patient is being told that they need to go to hospice care to live out the end of their life. So luckily, the patient was transferred to our center. I evaluated her. I decided to use TransLab. I felt that retrosigmoid, there would be too much brain displacement to get to the medial aspect of the tumor. So we did this TransLab, and plus it was a fresh operative site instead of going through a previously operated retrosigmoid corridor. But because the tumor had been irradiated, it was very adherent. I ended up leaving a cuff of the tumor along the course of the facial nerve. And at 9 to 10 years, you could see this area has remained rather stable. And you could see she had all this hair loss from the radiation she had. She was bedbound, quadriparetic. And at 2 months, she was able to walk. And I've seen her now for more than 12 years now. And she's lived a normal life. So that was a life-saving procedure for her. No hospice care for her. So what is this hybrid approach, hybrid strategy? In a recent meta-analysis, this is called a nerve-centered approach. It's nerve-centered because the goal is to try to preserve the facial nerve. And if you look at the follow-up, it's rather short, but the overall tumor control rate looked very favorable. 93%, 94%, and the facial nerve preservation is 96%. That's pretty good, 96%. And these results look very favorable. Perhaps this is the way we should be treating large CUS grade 3 and 4 tumors. Do you think? Do you think this is the way? Is this the way we should be treating large tumors? So we give everybody this Macintosh apple core resection. So I don't think so. And these are my own personal criticisms. My criticism is that the mentality going in is the subtotal removal is already pre-planned. It's already decided. I'm not even going to try to remove the tumor. I'm just going to go in, remove the middle of it. And the debulking, if you read the literature, the debulking is only intracapsular. There's no attempt to come around the outside of the tumor. You just stay in the middle. And when you stay in the middle, it is very difficult to assess the volume of residual. That stealth navigation is not going to tell you how much is left. And you end up underestimating how much tumor is left behind. And so you end up leaving a rather big residual. And it's important to know that there's a huge spectrum of subtotal removals. This technique is lacking long-term follow-up, and we don't know what's going to happen in 10 to 20 years. Are we creating a new emerging disease? You know, these large residual tumors that have been irradiated. And as an educator, as a professor, as a person who trains residents and fellows, are we forgetting how to do safe and proper facial nerve dissection? And how are we going to, as educators, teach our future generations of our trainees? And if we don't know how to perform facial nerve dissection on an acoustic neuroma, how are we going to perform more complex surgeries for other pathologies like paragangliomas, meningiomas, chordomas? So I think if we don't preserve this skill, just like microsurgery clipping of aneurysms, facial nerve dissection will become a lost art. And we have to preserve microsurgery. We have to preserve this skill, this craft that we've developed for many decades now. We have to preserve the ability to do this kind of surgery. So does it matter how much you leave behind? The answer is yes. If you look at the literature, there's a great correlation of volume of residual tumor and the risk of recurrence. So the extent of resection does matter. It is very important. In this study, you can see that if you look at the subtotally removed tumors, there's a 13-fold risk of tumor recurrence compared to a near total. So if you can get as close to a gross total resection as possible, a near total, it's much better. So the extent of resection matters again. And like I said, not all subtotal resections are created equal. Okay, this is my classification scale of subtotal removal. This is barely visible residue. This is the carpet, and then this is the chunk. We want to avoid the chunk, and we want to aim towards this spectrum of the barely visible if you're going to leave some tumor behind. So how can we achieve maximal tumor section, leave the least amount of residual, and still achieve best facial nerve outcome? My personal strategy and philosophy is that we should attempt to perform a gross total in all cases, if safely possible. And if you're going to leave tumor behind, that decision is not made before surgery. That decision is made during surgery based on your intraoperative observation and judgment. And that if you do leave tumor behind, you want to leave the least amount of residue behind so that in effect, you maximize the extent of tumor section and you get a radical near total as possible. And that's my philosophy. The technique that I find very useful in doing this is the technique described by Sasaki called the sub-perineural dissection technique. And in this cartoon, you can see that the tumor is wrapped around by a layer of vestibular nerve. And as the vestibular nerve courses around the dorsal surface, it's very thin and it's very stretched. And also on the ventral surface, it becomes very thin and very stretched. And this layer, if you preserve it, acts as a good plane of cleavage where it can protect the facial nerve and in some cases, the cochlear nerve on the ventral side. This is what it looks like at surgery. It's a very clear membrane. Sometimes people mistakenly call it arachnoid. They say, oh, peel the arachnoid off of the tumor. It looks like arachnoid, but it is not arachnoid. It's a connective tissue that is stretched from the vestibular nerve, the perineurium. So we call this the sub-perineural layer. I like to call it onion peeling. So it's like peeling an onion, where you open the layers of the onion, where the vestibular fibers are the dry, crusty parts of the onion, and the true tumor capsule is that moist core of the onion, so that when you peel the tumor, you stay close to the smooth part of the onion, and that the dry portions of the onion act as a protective layer to cover the facial nerve. So by the time you remove the whole tumor, it should look like a glove or like a baseball catcher's mitt. So here is a medium-sized tumor. This is retrosigmoid approach. We've drilled out the IAC first. I like to do the IAC portion first because I have early control of the facial nerve in the fundus. Then I come out to the medial side. Now this is arachnoid here. This is the arachnoid cistern. You can undress the tumor and peel the arachnoid off of the tumor's capsule. Then we hollow out the tumor like a canoe. And then we can start peeling the perineurium. This is the clear membrane. This is not arachnoid. The clear membrane of the perineurium around the tumor capsule. We're working around the medial side of the tumor. And then we're using the dissection device to peel the tumor capsule away from the perineurium. And then we pick up the vestibular nerve on the superior side. There's the vestibular nerve. This is the vestibular nerve, superior vestibular nerve. And then we connect it to the IAC side. And then we're using the disc dissector to push away the perineural membrane. It's important to not use cautery. Cautery can injure the nerve. So a little bit of oozing, I just pack it off with Bicol and little Surgicel, and you can stimulate the facial nerve. Look how it looks like a glove. You don't see like a strand of facial nerve. Everything looks like a glove because you have a perineural layer protecting the facial nerve on the other side. And he is House-Brackman grade 2 after surgery, complete removal, and it quickly resolved to a Brackman 1 at 6 weeks. So this one, next case, is a much larger tumor, big cystic tumor, much more challenging. Here we're peeling off the tumor to find the lower cranial nerves. And now we pick up, this is the inferior vestibular nerve fiber layer, and I can use the scissors to spread. And this is the perineurium. You can see this is like a clear membrane of nerve tissue. This is not part of the tumor. You have to find this nerve layer, and then you follow it all the way around. We can follow it. This is the IAC side. We peeled the tumor from the IAC, and this nerve layer protects the brainstem. Look how there's like a layer of tissue floating. That's like a veil of tissue protecting the brainstem. Here's the trigeminal nerve near the tentorium. So now I'm in the CP angle cistern, but now I come back, I find the superior vestibular nerve branch, and now there's a thin perineurium. There's the facial nerve. Look how the facial nerve is floating. It's floating behind this veil, not arachnoid, this is the perineurium. You can see how the facial nerve is protected. It's protected by this layer. It's floating nicely. And then now I can peel that perineural membrane off of the tumor capsule. And then push the membrane away from the tumor capsule. And then where the tumor is adherent, this is where you use sharp dissection and you can trim the tumor, leaving microscopic adherence. And this is where I made a decision. I'm going to leave a little microscopic residue. There's a small little residue here. It's very adherent to the membrane. I'm going to leave that behind and then stimulate 0.05. And this is the patient in the recovery room. This is immediately after surgery. Normal facial nerve. This is the post-op MRI scan. So a great result in my mind. This is one that we did translab. You can see another cystic tumor, very challenging cystic tumor. Here we're spreading the arachnoid membranes and we're undressing the tumor, peeling the cerebellar tissue medially, and then just carefully dissecting around the tumor. And so here we've started dissecting the tumor from the brainstem. Here we're dividing some vestibular nerve fibers on the proximal side, trying to get into that subperineural layer. And so oftentimes there's a combination of using scissors dissection, micro bayoneted forceps to dissect. And here's the facial nerve. This is the facial nerve. We're carefully peeling the subperineural membrane off of the facial nerve. This is the course of the facial nerve here. It's on the dorsal side. And there's a thin layer of perineurium over the facial nerve. We could cut these vestibular fibers and then use it as a protective layer. And then we continue to follow the course of the facial nerve all the way around using sharp dissection. And then using this disc push away technique. Here's the use of a McIlveen knife, which is a nice angled hook that has a blade on the curve of the hook. It's always important to periodically debulk the tumor. You have to debulk the tumor to allow it to collapse, then you can come around the tumor. And here is where the tumor often gets adherent. It's right where the tumor exits the porus acousticus. So here I use sharp dissection and I'm trimming. I leave a tiny residue here. Here's where it's really stuck. And I trim it using sharp dissection and I can release it, leaving a tiny residue on the facial nerve. And this is how I achieve that radical near total, by using sharp dissection and careful trimming, leaving just sub-millimeter thickness of tissue on the membrane. I try to keep that membrane intact. A little bit of oozing controlled with Surgicel, gentle packing. You can stimulate here the brainstem. And then this is the fascial sling technique to do the repair. This is the near total removal. You can see barely visible. Here's a subset of large tumors. These were all near total. This one was a gross total. And look, excellent facial nerve outcomes. And then here's another subset of large Coos grade 4 tumors. Excellent facial nerve outcomes. Here's one I did not too long ago. You can see this large cystic tumor filling the CP angle. This is immediately in the recovery room. So a little bit of weakness, House-Brackman grade 2. So what we found is that when you use the subperineural dissection technique, the recovery after a facial palsy is very fast. You don't have to wait 1 to 2 years for recovery. This patient's nerve recovered in 6 weeks back to normal. And then here's a patient who had failed radiation. It was actually my patient where I thought I did a near total and the tumor started to grow back. I gave her gamma knife radiosurgery, but despite this, the tumor continued to grow. And I went back and removed it. I got a near total and she had an excellent facial nerve outcome. So you can still do this even after radiation. It's more difficult, more challenging, and probably more risky. But if you find that plane, you can really achieve great outcomes. This is one of my cases earlier in my career. Big tumor, translab. This one was a Brackman 3. So this is a not as good favorable outcome, but the nerve was preserved. But you could see he has good symmetry at rest, but when he forces a smile, he's got some asymmetry here. So we've been able to achieve 95% facial nerve outcomes. This is an outdated slide. We're up to 150 patients now using this technique, but probably this is as good as the hybrid technique. And most of the tumors were large Coos grade 3 and 4 tumors. And if you look at our outcomes, the small tumors, we can get 100% normal facial nerve outcome, and then the larger ones, about 92%. So the larger tumors are obviously more challenging. And you can see that as the tumor size gets bigger, there's an increase with near total removal. So what that means is that as the tumors get larger, my decision to perform a near total increases. And there's no impact on the facial nerve outcome, whether you're doing a gross or near total in our series. And the recurrence rate is low. It's about 1.4%. Complications, of course, surgery is not without complications. We had 2 patients that had cerebellar edema from the retrosigmoid approach, likely from retraction. Some graft site complications. 2 patients had pseudomeningocele, but there were no incisional leaks. And I attribute the low rate of CSF leak due to the repair techniques that we've reported in the past. This is our technique for retrosigmoid using a fat graft over the suture line. And then this is the fascial sling technique. So if you compare my results to the hybrid technique, the facial nerve outcome is about similar. And the degree of resection, of course, obviously is going to be better when you do a radical gross to near total. And very few people require radiation afterwards because of the low rate of recurrence, whereas 100% in the hybrid technique require radiation. So I would argue that good microsurgery can also be a nerve-centered approach. Okay. So in conclusion, you can achieve excellent facial nerve outcomes and you can achieve maximal safe tumor resection. You can do both. It doesn't have to be one versus the other. And this technique of the onion peeling subperineural plane of dissection is the key to providing a good buffer to protect the facial nerve. And your decision to leave tumor intraoperatively should be based on an intraoperative judgment, not preemptive planning. I would argue that this is a nerve-sparing centered approach, and we have to continue to raise the bar of microsurgical techniques and results. Thank you again for your time. I'll take the time to answer any questions that you have. Thank you.
Dr. Leo, thank you very much for wonderful presentation. I have done so many notes. I would like to ask a few questions. So first, at the beginning of your lecture, you mentioned about collaboration with skull-based team and with ENT department. So do you use in your practice combined approach with ENT people, or do you do by yourself everything, and translabrentine especially?
Yeah, in our team, we work with ENT neurotology. We've had a great relationship for many years, and it's been a great collaboration. I think there's a lot of advantages to working with ENT. Certainly they provide expertise when it comes to audiological issues, especially, post-op, if patient needs some kind of hearing rehabilitation or hearing aid device, you need their expertise to help guide the patients in terms of options. But yeah, it's a great collaboration. A lot of times the patients sometimes see an ENT doctor first, and so a portion of your referrals will come from the ENT, and a portion of your referrals will go straight to you. So I think it's nice to have that collaboration.
Thank you so much. And the second question, we were talking about facial nerves outcomes a lot today. And after your surgery, do you send your patients for rehabilitation, something like facial nerve stimulation therapy, when they have Hausbreckman 3 or 4? And what is your opinion regarding facial nerve repair, like facial nerve hypoglossal anastomosis or something else?
Yeah, no, that's a great question. Yeah, certainly if someone has facial palsy after, we send them to rehabilitation, pretty standard. And the question of reanimation, that's a very good one. I think if you're doing acoustic surgery, you should collaborate with a facial plastic surgeon. Usually they're ENT facial plastics who specialize in these facial reanimation procedures. We have a great collaboration with a colleague of mine, Dr. Boris Paskover, who specializes in these. And I think the facial nerve transfer has been an important game changer for people with pretty bad facial palsies. That you mentioned the hypoglossal 12/7 transfer, which has traditionally been used. However, that will result in tongue weakness. The one that I think has been used more frequently in our center is the 5/7, the mesenteric facial nerve transfer, and it really helps mobilize the midface. And patients do quite well from that. The question is always timing. Certainly you want to wait for the facial nerve to recover. And if it recovers, you don't need a facial transfer. But, obviously if it's not, recovered after, 1 year or so, you might want to consider that. So it's important to work as a team, multidisciplinary fashion. And this is very useful to have this in your practice.
Thank you. Recently I was listening the lecture from Chinese Grand Rounds from Professor Binzu. So from his team, there was probably she was plastic surgeon, and she was talking about facial nerve repair. She told that at least if you have 2 years, you will be able to save and repair facial nerve. And she was giving amazing examples about transplantation of vascularized gracilis muscle, hypoglossal nerve, and facial nerve stimulation as well. The question is how many countries use these techniques and how much it developed. So I was just wondering how it is in USA. Thank you. Any questions from the audience? Probably.
Yes, Dr. Myla has a question. Dr. Myla, you want to ask a question, please?
Yes, thank you very much. Professor, I just have a question. My name is Dr. Mila, and I'm originally from Saudi Arabia. I'm currently a first-year neurosurgical resident here in Russia. And my question is, since you gave an excellent presentation, I would like to know what is the best advice you can give a first-year neurosurgical resident on how to like study this chapter in a very well manner, because here the curriculum is a little bit in Russian, and I just want to make sure that I have it properly in English at least.
That's a great question. I mean, I think the way we learn is we learn, in multiple layers. So when you start out as an entry-level resident, you're learning the basics of the disease, basics of the clinical presentation, the treatment options, etc. And, that's a lot of the book learning. And I think as you advance, we're trying to understand, a lot of the surgery and the surgical learning, and that takes a lot of time. And there's many layers to that. So I think, of course, finding good atlases that give you illustrative representations to understand the anatomy. Anatomy is key. And so it's very important to have a good foundation of neurosurgical anatomy, and find every opportunity to go to the operating room, and whether it's to assist, but even if you are observing, try to develop a way to be able to pick up details as you're engaging in deep observation. And you can learn a lot of, anatomy while you're doing that, watching the display and the microscope. You're looking for techniques, and of course, being able to rehearse and practice some of these techniques. So many layers to learning. Obviously, learn the basics from the textbooks, but then the surgical learning. I think in this day and age, you have so many opportunities to, watch webinars such as this, and a lot of online material that's free that was not available to me when I was in training. I mean, I would look at a textbook and I'm trying to figure out, well, how do you do this? I still don't understand from this textbook chapter. And they didn't have videos out there like this. So take advantage of the material that's out there. Of course, be selective to choose what is good and what is not so good. But yeah, you have so many resources now, especially available free and online.
Thank you, Professor.
We have one question, Professor, from Piotr Bajenov. Do you usually regularly perform a CT scan before the surgery? So what is pre-op plan? MRI, CT, what else?
Yeah, so we typically do a MRI, IAC protocol. That's internal auditory protocol with the stealth. So the IAC protocol is very thin, 3mm slices, so that you can also include a Fiesta scan, because I like to see the course of the cranial nerves and the relationship to the fundus. And then we use it for stealth planning, so we have navigation during surgery. And then we also get a CT scan of the temporal bone. So we study the temporal bone anatomy before surgery, so we can assess the relationship of the meatus to the posterior semicircular canal, so that we know how much we can drill when we're doing a retrosigmoid approach without violating the posterior semicircular canal if we're doing hearing preservation attempt. And also it's important if you're doing if you're considering a translab approach, you have to look for any anterior or high riding jugular bulb, sigmoid sinus, because that can minimize your working window that's not favorable for translab. So these are some important things that we look at when we get these imaging studies.
Thank you so much. As I can see on your operation recording, you prefer kind of wide craniotomy. Not wide, but at least not. You don't like a minimal invasive? Like, what is your opinion?
That's a great question. we use this term minimally invasive a lot. And, you know, I believe that minimal invasive equals no injury to the patient. Minimally invasive should not mean small opening. If you have a big tumor and you do a small opening, you may be limited and you end up manipulating more brain tissue or retracting more brain tissue. And if you don't have enough room to work, you can injure structures. So that's not really minimally invasive. I believe that exposure is everything. So if you do a bigger opening, what it allows you to do is sometimes you have a big tumor that's going all the way down to foramen magnum. And the first step of any CP angle surgery is what? Is to release the CSF. So if you do not go low enough on the posterior fossa is a bowl, right? It's like a bowl. And if you do a small opening at the transverse sigmoid junction, you cannot get low enough to the bottom of the bowl. So if you have a big tumor, you have to get around to the bottom of the bowl so that you can get to the lower cisterns and release the CSF early. Otherwise, you open the dura and the brain will just herniate out at you. So in these bigger tumors, I make sure I get all the way down to the bottom of the bowl so that when you open the dura, you can mobilize the cerebellum, open up that cistern quickly and release the CSF. If you don't do that, you can get into trouble and the cerebellum will spill out at you. What I always tell to the residents is nobody ever died of a bigger incision. Nobody ever dies of a bigger bone flap. But somebody can get hurt if you don't have enough exposure and you get into trouble and you make mistakes. That's my philosophy.
Thank you. Any questions from the audience? Professor Ahmed Firzad from Afghanistan want to thank you for the great presentation. Afghanistan Neurosurgical Society.
Yeah, there he is. You want to say hi? You want to say hi, Ahmad? Are you there, Ahmad? Perhaps not. He could be in a place where he can't speak. Okay, very good. Thank you, James. Let me just get upcoming events. Yeah, hold on here. Well, at any rate, we have Hyperion coming up at 10:30. So the link is on the Neurosurgical TV website. And so we'll wrap this up. Thanks a lot, James, and thanks everyone. Thanks, Nagiza, and thanks everyone for attending. But we had a good crowd. I was surprised. We planned this at the last minute. It worked out well. Thanks.
Great. Thank you, everybody.
Thank you.
Hi, Jens.
Oh, Dr. Harshat is here.
Yeah. Hi.
Good evening, sir.
Nice talk.